Excellent. I know folks will continue tuning in, and that's fine. I'm going to get us started on some logistics. So, the summit is more than just a discussion on women's health. We are here to empower practitioners, health professionals, partners, and women with knowledge, break down barriers, and foster a supportive community. Our goal today is to bridge the gap between medical research and personal health experiences to give you all a holistic view of wellness in the obstetric anal sphincter injury space. So we'll go over our logistics. We'll have an introduction of SOLACE, and then we'll hear from various experts in the field. So we have a research perspective before we'll take a short break. We'll have some clinicians share with us before another short break. And finally, we'll hear from one courageous woman about her experience with an obstetric anal sphincter injury. To kick us off, Caroline, our founder, will share a little bit about the origin of SOLACE.
Hey, good afternoon, everyone, and thank you so much for joining us for our inaugural summit today. I'm truly honored to be here with all of you. I founded Solace after experiencing a life-changing event during the birth of my daughter in 2022. During my delivery, I sustained an OAC, an obstetric anal sphincter injury. For those of you who may not be familiar, OAC is a serious complication that can occur during childbirth, resulting in injury to the anal sphincter and surrounding tissues. These injuries are commonly referred to as third or fourth degree tears. This injury had a profound impact on me, both physically and mentally. I found it incredibly difficult to carry out everyday tasks, including taking care of my daughter. I also battled severe postpartum anxiety and depression, yet my symptoms were often dismissed by medical professionals as normal, with many telling me to simply wait it out. I spent countless hours searching for resources and support, and that's when I discovered MASIC, a UK-based nonprofit that works to raise awareness, prevention, and support for those affected by OAC. As I began to heal after undergoing secondary repair surgery, I felt incredibly fortunate that my medical background helped me trust my instincts when I sensed something wasn't right. I knew I needed to find resources to guide my physical and emotional healing. This experience sparked a deep desire to empower women with the knowledge and resources they need for recovery, and that's how Solace was born. Our mission is modeled after MASIC, and our goal is to spread awareness, prevent OAC, and offer support to those affected. Over the last year, I'm proud to say Solace has gathered an incredible board of directors and a dedicated group of volunteers. Together, we've worked tirelessly to further our mission and create events like this summit, which we hope will serve as a valuable resource to all of you. Thank you again for being here with us today and being an important part of this movement.
Thanks, Caroline. So if you are here hoping to claim continuing education credits, I will give you some quick information on that. I already saw a question in our chat. We do want to extend a thank you to one of our co-sponsors for today's program, the Alabama Statewide Area Health Education Center. You can learn more about their programs and the center as a whole on their website, which is listed on the screen. The Alabama Statewide Area Health Education Center is an approved provider of continuing hours for nurses by the Alabama Board of Nursing. It's awarded this program 2.6 contact hours. This program has also been approved for Certified Health Education Specialist and Master Certified Health Education Specialist credits by the National Commission for Health Education Credentialing. You can receive 2.5 contact hours for this event. At the end of our webinar today, you will be given a survey. So to receive credit, you must be here for this training and watch the entirety of the program. You'll complete the evaluation following the program. The survey link will automatically pop up on your screen when the Zoom browser is closed. And once you complete the anonymous evaluation survey, you'll be linked further to the CEC form. You have 2 weeks to complete that form if you are trying to claim credits. For nurses in Alabama, CEUs will be awarded by the Alabama AHEC. And like I said, for all others, complete the CEC request form if you're looking for CHES or MCHES credits. And if for any other reason you would like a certificate of attendance, you can also use that same form. We will report credits to CHES participants within 60 days of the event. Great. The webinar is being recorded. If you want to put your name in the chat, feel free, but you do not have to do so. Please use the Q&A box for questions rather than the chat during our Q&A sections. And if you're having any technical issues, please reach out to us at contact@solaceforwomen.org. We have an incredible lineup of speakers here today, leading experts from the medical and advocacy communities, including a maternal fetal medicine specialist, urogynecologist, pelvic floor physical therapists, and lawyer who will share their knowledge and insights on vital aspects of women's health pre, during, and post OASI. We'll also hear from one woman sharing her personal story, adding emotion and real-world perspective to the science. Today wouldn't be possible without you, our audience. Your engagement, questions, and experiences are what truly make this summit necessary and meaningful. So we do encourage you to be part of the conversation, ask questions, and take advantage of the knowledge and community here today. Each of our sessions will be followed by a short Q&A where you can submit questions directly to speakers. You will use the Q&A box to do that in order for us to help moderate. Please use that instead of the chat. We will take short breaks in between our main sessions, and like I said, at the end of our time today, you'll be given a link to submit an evaluation and claim CECs. We will also send a follow-up email in case you missed those links today. While the necessary nature of the event can be considered unfortunate, I'm ultimately filled with pride and joy that we can offer this space to learn about OASI together. Solace began due to a lack of knowledge and resources regarding OASI, and this event signifies real progress being made in a very important arena. So I can't wait to see the incredible knowledge and insights that unfold today. Together, we're creating a space where women's health is prioritized and understood from all angles. Without further ado, I'll start introducing our first speaker. But first, a quick content warning. We do have a lot of diverse audience members today, so we would be remiss not to give you a quick warning that the summit does discuss obstetric anal sphincter injuries and related topics, including sensitive subjects such as infant death. Some sessions might include medical photos that could be challenging to view, so we encourage you to prioritize your well-being and take breaks as needed. Our first speaker is Dr. Bob Freeman. As a consultant and gynecologist, giving you control, Bob. In Plymouth, Bob set up a clinical and research urogynecology unit over 30 years ago. With others, he has helped with the Royal College of Obstetricians and Gynecologists OASI Care Bundle for the prevention of obstetric anal sphincter injury, as well as a risk assessment tool for identifying those at risk of long-term incontinence and prolapse, and the EpiScissors 60 adapted surgical scissors for the safe angle of episiotomy. He is a member of the National Health Service, England's Perinatal Pelvic Health Initiative Implementation Group, was previously a scientific editor for the International Urogynecology Journal. He helped form the British Society of Urogynecology as founding secretary in 2001 and was chairman from 2006 to 2009. He was president of the International Urogynecological Association from 2014 to 2016. His main area of interest is the prevention of obstetric pelvic floor injury, and he's written and lectured on this both nationally and internationally. He is now education chair for MASIC Foundation, which is the UK charity for women who have suffered birth injury. He is also a trustee for the Birth Trauma Association. Over to you, please, Dr. Freeman.
Well, good afternoon or good evening here. Thank you very much indeed, Amanda, for that very nice introduction. Thank you indeed for inviting me to come and speak with you all today. It's a great compliment to be asked. I'm speaking on behalf of MASIC, and as Carolyn and Amanda have told you, that's the charity for women who've suffered obstetric anal sphincter injuries, but also pelvic floor injuries as a result of childbirth. And the stories I've heard from many women are frankly quite heartbreaking, and I'm sure many in the audience today can identify with that. I am the education chair, as you've heard, and we arrange webinars like this, and you're more than welcome to come and join those. I'll send Amanda all the webinars that we have coming up. The only downside to it is it's 7:30 in the morning for you, but I'm sure you'll find them interesting, so do feel free to join. Now, the reason I got involved in all of this in the first place was because I've got this interest, as you said, in obstetric anal sphincter injury and its prevention. That's the important thing, to try and prevent this in the first place. And I was an obstetrician for the best parts of over 30 years, but I still am a urogynecologist. And so I see, along with some of the other speakers and colorectal surgeons, the consequences of these injuries, both in the short and in the long term. And these can be quite significant. So, can I have the next slide, please? It'll come up in a minute. But yeah, as I say, we see the consequences of this. Now, when I was still practicing obstetrics, I was seeing a large number of these anal sphincter tears. Now, yes, of course, from time to time you see these, but these were a large number that we were starting to see. And I spoke to colleagues around the country and they said, yeah, we're seeing them as well. So something was happening. Why this sudden increase? Well, next slide, please. This is what was happening. We actually saw a rise in OASI in England over this 10-year period. Next slide, please. Yeah, and it was a threefold increase. And I reckon that's an underestimate, but nonetheless, there was a considerable increase in the number of injuries. And these, as I've just said, are a major cause of anal and fecal incontinence. Now, for an elderly person to lose bowel control is bad enough, but if you're in your 20s or 30s, well, that's life-changing. As I say, when you look at all the stories we hear, the adverse impact on body image and self-esteem, the things that go with it, like urinary incontinence, painful intercourse, psychosocial disorders, and some of these comments that have been made by women from MASIC. You can read these yourself. So that's pretty heartbreaking. So what's happening with the OASI worldwide? Well, this was a study looking at 13 high-income countries, and they showed that rates of OASI in all these countries had gone up. And that was particularly in countries where they had higher rates of spontaneous birth. Unsurprisingly, women who deliver by cesarean wouldn't necessarily have that problem. Now, next slide, please. Why has this been happening? Well, first of all, I think it could be argued that there is a higher risk population of women today. Older women in their first pregnancies. Now, I know in some countries, pretty developed countries, the average age at first birth has gone up, and that's the case in the UK. We've also had the obesity crisis and type 2 diabetes, and as a result of that, bigger birth weight babies. But there may also be a reason for this increase. Maybe it's just we're reporting it better, we're identifying it better. Well, if that's the case, it means we've probably been underreporting it for a long, long time. But the third possible reason was the change in the management of the second stage of labour that certainly was happening in our country. The hands, as you'll see from the top picture here, the hands were not put on the perineum anymore. The baby was allowed to deliver without any support of the perineum, the bit between the vagina and the anus. There were very few episiotomies done, and those that were done were often cut too near the anus, so they actually tore into it, causing an OASI. And thirdly, in our country, we had a very high rate of forceps, another high risk factor. So, next slide, please. To the next slide, please. Yeah. So, what was happening in Norway was that they had a very high rate of OASI, and they were trying to do something about that. And this wonderful obstetrician, Katrina Laney, brought in this package of measures to see if they could reduce the rate. First of all, good communication. Then she brought in this thing, this perineal support using this hand grip, which is sometimes known as the Finnish grip, although she's Norwegian. Women would be allowed to be in a position that they felt comfortable with for delivery, but one in which the perineum should be observed. An episiotomy, and of course, only when it's clinically indicated, should be done, but at an angle well away from the anus. Next slide, please. What did they find? Well, you can see here there was a significant reduction in OASI rates over this 20-year period. And now in the first couple of years, there wasn't a great deal of difference, but you can see in the subsequent years, the rate has dropped considerably. So in the UK, we obviously took notice of this. Next slide, please. And I and others went to the Royal College because we were concerned about the number of injuries, bad injuries we were seeing. And a meeting was called between the Royal College of Midwives, obstetricians, a thing called the Care Quality Commission and NHS England. There was a fairly frank, open discussion about this. And a joint statement was made which said that as morbidity for women is considerable, that it can influence decisions about future births, prevention of trauma must be a priority. I would say preventing the consequences as well must be a priority. So we needed to do something. And one recommendation was that we produce what's known as a care bundle, a package of measures similar to the Norwegian one, to see if we could reduce the rates of OASI. Next slide, please. Now, what we did was we looked at the evidence from all the different interventions that you could use that might be able to prevent OASI. And then 4 were selected by a consensus team of obstetricians and midwives. And the 4 things that were chosen were good antenatal information for women, the manual perineal protection technique from Katrina is on the picture here. Episiotomy, and only when indicated, should be done at 60 degrees at crowning when the perineum is fully stretched, because otherwise, if you just try and eyeball this, it's very difficult to do that. And if it gets too close to the midline, as I said, it could create an OASI. And these scissors at the right are called epi-scissors that we developed. The bar is in line with the anus, and the angle to the blades is 60 degrees, so we know exactly the angle that's been cut. Now, that was piloted, this system, in 2 units, my own and the one in Maidie and Croydon, where Abdul Sultan and Rani Thakur, many will know. And let's see what we found. In the first big study done on this, next slide, please, there was over 50,000 women, a 20% reduction. That might not seem like a lot, but in the Norwegian study, in those first 2 years, they only found 20%. The subsequent years, it became an even bigger reduction. Now, what was interesting was the rates with natural birth dropped considerably, not so much with forceps. But the really interesting thing was that despite telling women about the risks of OASI and the consequences, namely potential anal incontinence, there was no increase in cesarean section rates. There was no increase in episiotomy rates. So the anxiety that if you start telling women about risks, they're all going to ask for cesarean section, might not in fact be true at all. Next slide, please. So we moved on from this to see if we could implement it nationally. Now, I don't have time to go through the whole study, but the bottom line was, next slide, please, that of the first 15 units that were in the study, those low rates of OASI were maintained. We had 20 new units where we wanted to see if we could use two different types of implementation. One was where somebody came in and taught the team. The other was where the team just looked at videos and written information. There was no difference between the 2 methods. But what was important was there was an opportunity to create mandatory training for all staff in hospitals and more accessible training resources, and to standardize consistent antenatal discussion so that there was help for women to make informed decisions. Next slide, please. So that's what we did, and the results were excellent. Now, if you're going to introduce something like this in your own country, it's only right to tell you that there were certainly a lot of challenges right from the beginning of this. Next slide, please. There was a lot on social media. A lot of well-known obstetricians and midwives were very critical of this whole initiative, saying things like controversial recommendations, which is based on terribly flawed research. I couldn't really understand this. Next slide, please. And I think the 2 reasons were, firstly, that there was an anxiety it would lead to more cesarean requests. As I've shown you from the study, there weren't any increased cesareans. And secondly, that women wouldn't like the rectal examination part of the care bundle. But in fact, a study has just been published which has looked into that very thing. And in fact, women didn't say that at all. They said, well, if you're doing something that's going to pick up an OASI and repair it, please go ahead and do it. They were not bothered about that at all. I think the real reason for the negativity was a lack of confidence by many midwives in being able to manage the perineum. Next slide, please. There were 2 big studies done which showed that the vast majority of midwives didn't feel confident in their ability to manage perineal trauma. They felt their teaching was insufficient, low levels of confidence about episiotomy. And in fact, 90% had finished their training without ever even having done one or repaired one. Next slide, please. So what's really been important is producing this training package, and you can photograph this. All these slides will be available later, go online. This is both for women and for healthcare professionals to learn more. And I think this did help a lot of our midwives. So things have changed considerably. Next slide, please. What we've also done is try to implement this around the whole country. And yes, in many centres, it's included in guidelines, used in all birth settings. It's taught in the labour rooms to all newly qualified midwives. That's what NQM stand for. And it's recorded so we know how many people have been trained. But we still have some continuing challenges. For example, that hand grip, the manual perineal protection technique, isn't done consistently, or the technique isn't done. A thing called warm compress can be used. It wasn't part of the care bundle as such, but it can be used as an adjunct, if you like. That's not often used either. And there's been variation in how much information is given to women, what we asked them to give and what is actually being given. So these are continuing challenges that we're trying to address. Next slide, please. So what we're going to do next. First of all, next slide, please. You heard about this perinatal pelvic health initiative that's been brought in England, not in the rest of the UK yet, which is going to provide physiotherapy and pelvic floor muscle training for all women after birth, because it's known to be the most cost-effective intervention to not just prevent urinary incontinence and prolapse, but also treat it. And it's also been shown to be effective in protecting against OASI. And one of the main recommendations in this initiative is the OASI care bundle. Next slide, please. Also, it's gone into our political arena. This politician here, Theo Clark, her name is, she unfortunately suffered a birth injury and managed to set up what we call an all-party parliamentary group. And they had several meetings and have come up with 12 recommendations. Number one being, yes, implementation of the OASI care bundle. In addition to things like antenatal education, birth reflection, support for fathers and birth partners. We want better training in assisted birth, like forceps and ventouses. Being able to risk assess women in the antenatal period so that women can be given individual information and allowed to make informed choices. If they have suffered an injury, then they can be signposted to MASIC or the Birth Trauma Association. And then we can introduce mandatory training and updates on perineal care. Next slide, please. So, as I said, if you want to learn more, look at the RCOG, the Royal College of Obstetricians and Gynecologists TARES Hub. There's a huge amount of information there, which I'm sure will be helpful for you in your own country. And I want to just acknowledge all the clinicians and women who provided feedback for the studies, the OASI 1 and OASI Care, OASI 2 Care Bundle teams, and the champions in those units who promoted this, and of course the Health Foundation who funded it. So thank you very much indeed for your attention. I'm very happy to take questions. Thank you very much.
Thank you, Dr. Freeman. That was excellent.
Pleasure.
We do have time for Q&A. So if anybody would like to put their question in the chat. I know I got a few. One question, here we go. Post-injury care resources for clinicians. A lot of my experience was clinicians don't see the physical effects of recovery once their patients leave the hospital. Have you any experience with that?
Well, that's absolutely correct. And I think, with all due respect to my obstetric and midwifery colleagues, they don't see the women long term. We obviously do. So we have set up in the UK OASI clinics, which have been set up all over the country. We're also dealing with primary care physicians, because I think there's been a perception that, I think as mentioned, Caroline mentioned earlier, you know, you go to your primary care physician and they say, well, it's just part of having given birth. No, it's not. And so I think more women are now being referred on to these clinics, which are run by both midwives and physiotherapists. And then they come and see us for further investigation if necessary.
Okay. Why do you think we still continue to see the hands-off approach of the perineum by some colleagues on the labor ward midwives, and what can we do about this?
That's a very, very good question. And I think it's a matter of education. It's a matter of explaining to people. There are some people who believe that hands off the perineum is right. We'll quote several papers. The problem is these studies were not looking at OASI. They were looking at other things, like perineal pain and so on. And I think we have to give them the facts and show that the results of not just the OASI care bundle, but the Norwegian studies have shown a massive improvement or reduction in OASI rates. And I think that's the important thing is getting that message across and listening to women who've had these injuries. I think a lot of midwives don't actually see these women again. So they don't actually hear what you and I and hear from people at MASIC and yourselves in SOLACE. So I think when they hear what's happened, they'll do everything in their power to try and prevent OASI. And part of that is getting the hands back on the perineum.
And as a follow-up, you might not have this data in front of you, but do you see a difference in the rate of OASI depending on the background of the clinician at birth, meaning are midwives versus OBs having different outcomes?
Ask me that again. Sorry, the midwives as opposed to?
Is there a different rate of OASI experienced based on the background of the clinician who's providing support during labor?
Well, in the UK, of course, the vast majority of natural births are done by midwives, whereas the assisted birth, in other words, forceps and ventouse, will be done by the obstetrician. And we know that forceps are associated with a relatively high rate of OASI. And what we're doing at the moment is what we call a consensus statement, where we've got lots of different groups of obstetricians and different specialist societies to see how we can reduce the rate of forceps, but maybe look at the alternative of vacuum, because that's associated with a lower rate of OASI. So from the obstetrician's point of view, yes, there may be a higher rate of OASI because of forceps, so if we can change that to vacuum. And from the midwife's point of view, it's getting the hands back on the perineum and using the care bundle package.
Okay, great. I have a couple other questions that were sent to me directly. Well, one person would like to say thank you so much for validating the lived experience of a lot of women who experience OASI, Dr. Freeman. One question that I had, obviously our health system is very different in the United States. How did you get an audience with RCOG? How did you find such support to implement this standardization in hospitals?
Well, the first thing was, as I said at the beginning, I was very concerned, and others were too, about the very high rate of OASI, which was something new. And I knew the president of our college, and I went to him and I said, I'm not happy about this. We really need to do something. These women we're seeing a lot of more and more younger women coming to us. And he agreed, because in his hospital, he was having the same problem. So he called that summit meeting. So that's how that whole thing started. And then within the summit meeting, it was recommended we produce a care bundle, and the Royal College then went on to do them. I hope that answers the question.
Okay. Thank you. Do you see, some folks are asking, is there any relationship to your knowledge between too fast or uncontrolled pushing and OASI? I've seen a couple questions about pushing.
Yeah, I think the whole care bundle is on the basis of a slow, controlled birth. I think that if the hands on the perineum and on the head and slowly controlling the delivery of the head, that's important. If you allow too fast a delivery and without any hands in the perineum, then there is a risk of tearing. Yeah.
Okay. And on the same thread, as far as slow, controlled pushing, is there any data that you've collected regarding a specific birthing position that seems to have the best outcome?
No, I think what has been shown, certainly in the Norwegian studies, as long as you can visualize the perineum as the obstetrician or midwife, then that's fine. I don't think it matters too much. Women on all fours, you can still be able to do manual perineal protection. I think the only position in which you cannot do it is in water for a water birth. Unfortunately, there's some studies showing quite a high rate of OASI with water birth, simply because you can't visualize the perineum.
That makes sense. Okay. Before I switch gears, because we've got a couple more questions about birth, and then I'll switch gears a little bit. Do you have any information regarding rates of Pitocin use in the UK and intervening during labor versus not, that could lead to different OASI outcomes?
That's a good question. I don't think there's any evidence for that in terms of augmentation of labor, that whether or not that is likely to lead to OASI. I think there are other risk factors that are there For example, as I said, older mothers, I think big babies, prolonged labours, and instrumental birth. But I don't think there's any evidence per se of augmentation with oxytocin.
Okay.
Switching gears a little bit, and hopefully this is all right. Oops, I just moved on me. There's also levitator avulsion with rotational instrumental births. What is your opinion on this? Should we continue doing mid-cavity rotationals, in your opinion? Should we also counsel women about levator avulsion as a risk?
Yeah, I think that's important as part of the antenatal counselling. I'm always going to do that in a way that you don't frighten people. But on the other hand, I think it's important to point out what the risks are, but what you're going to do about it. And that's why that perinatal pelvic health initiative is important. So that levator avulsion may, to some extent, get helped with physiotherapy afterwards. But I think in labour, if somebody has clearly got an obstructed labour, and we keep going back to the augmentation, putting up syntocin to try and get them to full dilatation so that we can achieve a vaginal birth, I'm not so sure if that woman's at high risk. I'm not sure if that's a sensible thing. I think in some cases one should say, look, this woman's a high risk of developing an OASI. Maybe we should seriously consider a cesarean section much earlier in labour, rather than waiting to the very last minute and then trying to do a difficult rotational birth. Of course, there's going to be situations where a baby's distressed and you're going to have to do a mid-cavity rotation to get that baby out quickly. But if it's not that, then one has to think, what are the consequences of that mid-cavity rotation? And in some cases, particularly if they're at high risk, as I say, big baby, that head's a little bit high, then maybe we should think about an earlier cesarean.
Okay. Another kind of switching gear question. Obviously, I've mentioned our government is set up very differently and our healthcare system is very different. In maybe what you know to be true of our differences, do you have any advice for us over here to help convince doctors of the importance in taking OAC seriously? I know a lot of folks on the call, a lot of women in our support groups don't necessarily feel like that burden is quite understood.
Well, first of all, I think it's the bottom line here. Most important thing is listening to the women who are on this call. And I think what MASIC did was they then approached a lot of the women in our parliament, our members of parliament, our politicians, and they took it forward. And we found quite a number of politicians who themselves had suffered third-degree tears. I gave evidence to that inquiry I was telling you about, and several of the members of parliament, politicians, that they'd had a third-degree tear. So I think that would be the way forward. I think if you start trying to do it through the healthcare professionals, I don't think it will work. They won't listen to us, but your government will listen to the patients.
Okay, thank you. And I think we have time for one more question. Let's see. Do you think doctors should spend more time assessing individual risk factors for OAC before giving advice and deciding on delivery mode?
I think that's an excellent question, and I think the answer is yes. We know the risk factors. For example, if you're older, you got a big baby, you've got high BMI, maybe a short perineal body, woman's short, baby's big. I mean, in someone like that with a whole, 4 or 5 different risk factors, I think you're duty bound to explain that to the woman and say to her, look, there are some risk factors, but this is what we'll do. If during labour it looks as if there's obstruction, then we might recommend an earlier cesarean. If you deliver naturally, we'll of course get physiotherapy afterwards. So I think it's important to explain that. Now, there have been some risk calculators produced. There's an excellent one called Your Choice, UR-choice, which is looking at the long-term risks for that individual woman of incontinence and prolapse and bowel incontinence. And there's been some done for OASI as well. The evidence isn't quite clear about that, but I think it's a really useful thing to have as a risk calculator to give that woman her own individual risk, and then she can make informed choices. More work's needed on these, of course, but they're in all other parts of medicine. You see it in preventing heart disease, breast cancer, prostate cancer. They have these risk calculators, and I think it would be really useful for these ones to be fully validated and used for OASI and pelvic floor damage.
Thank you. I know that's something we talk about a lot at Solace, the need for more education. I think a lot of women experience birth education, and tears are very much glossed over quickly and not really explained as a serious risk. So thank you so much.
Sorry for interrupting. Just say,
It's
do you
okay.
have that very last slide I showed? Please feel free to send those out to the participants. If I'd recommend you go onto the Tears Hub, which tells you that's both for women and for healthcare professionals, gives you a huge amount of education and information.
Sure. Thank you so much. We will absolutely share these resources out after the summit. Thank you, Dr. Freeman. And thank you,
Pleasure.
everyone, for your questions. There were a lot of other questions that came in that I know our next two speakers will touch upon. So that's why I pushed some of them over for now, but I am taking notes of all of your questions.